Needle Access Subdural Port, or NASP for short, is a closed suction device system which was developed for the treatment of subacute and chronic subdural hematomas by creating a homogeneous negative pressure throughout the subdural space that promotes drainage of the subdural collection and brain expansion without entering the subdural space. NASP is also indicated in cases of acute subdural hematomas in anticoagulated patients with impending transtentorial herniation, where anticoagulation cannot be promptly reversed, or in acute subdural or epidural hematomas as a temporizing measure if a craniotomy cannot be immediately performed, in cases when a neurosurgeon or the OR are not readily available, or the patient cannot have general anesthesia. Generally, insertion of one port is enough, but a maximum of 3, if needed, can be inserted without causing any adverse event, such as hemorrhage. Multiple ports may be indicated if there are septations in the subdural space, or the subdural collection is very dense, such as in acute subdural hematoma. According to Poiseuille, flow through a tube would be expected to follow the following equation. Flow rate equals pi times the pressure difference times the tube radius divided by 8 times the fluid viscosity times the tube length. The pressure difference of the subdural hematoma and vacuum bulb and large tube radius increases flow, while fluid viscosity and long tube length decreases drainage. Therefore, in acute subdural, in which the viscosity is very high and the blood may clot, 3 ports may be necessary. The entire value of this equation will be further discussed at the technique section. Technique. 1. Review CT scan. Identify the side of the subdural and locate the area of greatest subdural hematoma thickness. Measure the distance between the skin and the center of the subdural collection. 2. Patient positioning and anesthesia. The procedure may be done under local or general anesthesia with or without sedation. Depending on the degree of urgency and/or the situation, such as availability of the OR, the procedure may be done in the patient's room, ICU, or ER. The patient is positioned supine on the operative table with the patient's head rotated to the opposite side of the procedure. The head should be positioned at heart level or slight Trendelenburg in order to mildly increase intracranial pressure, which should increase drainage of the subdural hematoma following the insertion of the NASP, promote brain expansion, minimize entrance of air into the subdural space, and to avoid that the drill bit just pushes the dura without entering the subdural space. The counterpressure by the hematoma will facilitate the drill piercing the dura and subdural membranes. 3. Scalp marking and draping. Following target location on the scalp, as suggested on the CT scan, the skin is prepped, marked, and draped as per protocol. It is recommended that the incision be as close to the target as possible, but safer to err towards the skull base, which is further away from the sinus and adjoining veins, and also to take advantage of the effect of gravity to increase drainage. 4. Skin infiltration and incision. Infiltrate the skin with lidocaine containing epinephrine for better skin hematosis. The incision should only be approximately 5 mm long. A skin retractor is not needed. 5. Twist drill skull perforation. The NASP drill has unique features. One-piece electric drill with the drill bit and stopper built in. The drill bit has laser marking measurements in centimeters, so no ruler is needed to set the stopper. The stopper is moved up or down simply by a rotation of a cylinder around the drill bit. Maintaining clockwise rotation during insertion and removal of the drill, bone fragments are removed by the drill bit. To reverse rotation of the drill bit for removal from the skull should therefore be avoided. The drill bit has 2 cutting flutes. The tip of the drill bit is very sharp to easily perforate the skull, dura, and subdural membranes. Sharp tip also avoids skidding on the surface of the skull. If repositioning of the stopper is desired, the drill bit may remain within the skull. 6. Insertion of the NASP. Once the subdural space is entered, fluid under pressure should spurt out of the subdural space. Only then insert the NASP. If no fluid comes out of the subdural space, it is possible that the dura and subdural membranes were not traversed, or the location of the twist drill is not correct and needs to be redone. Do not insert the NASP if no fluid is observed to escape through the twist drill hole. It is recommended that the bone tapper available in the kit be used prior to the insertion of the NASP to create threads in the bone which will facilitate entrance and increase purchase of the subdural port. The twist drill bit is 6.32 mm in diameter, which is larger than the size of the standard hand drill bits available on the market. The threaded end of the NASP is conic, starting at 6.5 mm, extending to 8.5 mm, so it will engage with the bone and be very tight, thus preventing loosening, disconnection, and overpenetration of the skull. The NASP is made of an engineered transparent polymer that is much less thrombogenic than metals such as titanium or stainless steel. The NASP is threaded to the skull and connected to a 60 centimeter long silicone tube and a 100 cc suction bulb. The bulb should be squeezed side to side and closed to generate negative pressure. Squeezing the bulb bottom up generates very little negative pressure, -3 millimeters of mercury versus -111.6 millimeters of mercury. Although the pressure generated by a fully compressed empty bulb is high, a 60 centimeter long 16 French NASP tube will decrease fluid flow rate, or pressure difference between the bulb and subdural space, by approximately 85% based on the literature. Also, if the bulb is 25% full, it generates 50% less negative pressure. If the bulb is 50% full, it will generate 68% less negative pressure. Therefore, the suction bulb should be emptied when 25% full to maintain adequate negative pressure. Following insertion of the NASP, especially if the subdural hematoma has a large acute component, the surgeon could inject through the needle access port 500 units of heparin sodium, USP porcine, preservative-free, 0.5 cc, into the NASP lumen and tube to prevent intraluminal coagulation of the blood and plugging of the system. Betadine ointment should be applied around the port operative site, followed by light dressing. The vacuum bulb should be clipped to the patient's gown, and the silicone tube may be taped to the skin to prevent disconnection. Post-op care. Antibiotics should be continued while the drain is in place. Patient should be kept supine with a pillow for at least 12 hours following the NASP insertion to enhance greater subdural fluid drainage and brain expansion. Empty the suction bulb PRN as needed if filled greater than 25% and apply maximal negative pressure. Obtain a CT or MRI scan the day following the surgery to check the size of the subdural. If the brain has not yet fully expanded, there may be some air in the subdural space and residual fluid. The preoperative brain shift or the mass effect should have improved. If the preoperative symptoms have resolved and drainage has stopped, the NASP may be removed. It should be noted that since the NASP system is entirely made of polymer and silicone, there is no contraindication for MRI and no artifact with CT or MRI imaging. If, however, postoperative CT still shows significant mass effect, and especially if preoperative symptoms have not resolved or improved to some degree, then the system may be plugged and action should be taken. Since the NASP and tubing are somewhat transparent, the area of flow obstruction may be determined. Start by stripping the tube. If that does not work, one may consider injection of a thrombolytic agent into the clot through the access ports. Full negative pressure should be maintained during this maneuver. One can also advance the needle into the subdural space and directly aspirate the fluid collection. A 4 centimeter long needle, 20 or 22 gauge, will just protrude beyond the proximal tip of the NASP and is safe to use. Since the NASP is transparent, one can follow the tip of the needle by direct vision and also locate the clot. Although rarely indicated, since there are 2 access ports, the system may be simultaneously irrigated and aspirated. If all fails and the patient is symptomatic, consider a craniotomy or augmentation of the twist drill hole or insertion of a second NASP at a different location. If, however, the patient's preoperative symptoms have resolved and CT shows that the mass effect has improved, the port should be removed. Place the patient flat in bed to avoid air entrance into the subdural space, rotate the port anti-clockwise, and remove it. Apply antibiotic ointment to the wound and close it with a single staple. No anesthesia is usually necessary, but patient may require slight sedation or the skin sprayed with a topic instant anesthetic agent such as ethyl chloride. Patient may be discharged in a follow-up CT obtained in a month with an office visit. It should be noted that a twist drill hole as opposed to a burr hole leaves no scalp depression or cosmetic problems except for a 6 millimeter scar. There is approximately a 10 to 20% chance of chronic subdural recurrence following this procedure, which is a similar or better outcome than standard burr holes or craniotomy. For recurrent subdural, the following options are available. 1. Percutaneous needle aspiration of subdural hematoma if it appears to be chronic, utilizing the same twist drill hole, but entering through an area of clean skin, i.e. not through the previous wound in order to prevent infection. 2. If the subdural is in the same location, NASP reinsertion may be considered, but it is preferable to go through a new incision at a new site in order to prevent infection. 3. If the area of greatest thickness is not the same, insert a new NASP at this new site. 4. Craniotomy is indicated if there are multiple layers of subdural membranes. In summary, the main advantages of the NASP system are minimally invasive, fast, portable, it does not touch the brain and may be performed under local or general anesthesia in the ER, ICU, patient's room, or the OR. It leaves no skull deformity and subdural recurrence rate is low compared to other treatment modalities.